I would now invite Vivek. He's a budding nephrologist. I won't call him budding, he's already bloomed. So, he's an associate professor of nephrology at PGI. And he's going to talk about cardiorenal syndrome.
Thank you, Chairperson, sir. So I would like to thank the organizers for giving me this wonderful opportunity to, come to Goa again. I was here about 2 years back, and it's a wonderful place. So the topic which I was given was ED, emergency room approach to cardiorenal syndrome. So if you look at this topic, what does it actually mean? So it gives us a clinical situation. That means that we will be talking about disease of the heart and kidney in the same patient. The setting would be an emergency room or an emergency department. And if we talk of approach, then what we need to do is that we need to, rapidly establish a diagnosis and guide appropriate management. That is what to do. And another thing which is equally important is what not to do in such a setting. So if you look at syndromes, there are so many syndromes in clinical medicine. So when we talk of a syndrome, what do we actually mean? Well, syndrome is just a constellation of clinical manifestations which are temporally associated in time or which temporally occur together in one particular patient, and we feel that these clinical manifestations, they may be from different organs, but they are linked to each other, either through a common pathogenetic mechanism or there might be different pathogenic mechanisms in different organs, but these mechanisms would be interconnected to each other. Now, as the name suggests, cardiorenal syndrome, so we would be talking of a syndrome where we have cardiac and renal involvement in the same patient. When we talk of renal failure, usually what we mean by renal failure is a fall in glomerular filtration rate. Now this fall in glomerular filtration rate actually is clinically picked up as either an elevation in serum creatinine or a fall in urine output. When we talk of cardiac failure, we usually talk of failure of the pumping action of the heart. And how does it manifest? It manifests as either an inability to maintain circulation in the form of that we would have a poor tissue perfusion or a low blood pressure. And because of this, we will have a congestion in the circulatory system. And we know from our clinical experience, both in emergency department, OPD, as well as the inpatient wards, that both these things can occur together. They can be acute or chronic. They can precede or succeed each other. That is, we will have various permutations and combinations of both cardiac and renal failure occurring in acute and chronic settings, occurring before or after each other. So if we look at this, then it's easy for us to understand that if we want to classify cardiorenal syndrome, this would be the usual classification. So we will have 4 syndromes depending on whether the heart failure is acute or chronic and whether the associated renal failure is acute and chronic. And we'll have another situation. Now in these situations, we presume that the underlying mechanism is the same disease. That is, one disease is leading to another disease. And another situation that we know occurs in clinical practice is that the disease is another systemic disease which is simultaneously affecting both the heart and the kidneys, which we now categorize as type 5 CRS. So this classification actually doesn't have too much of meaning. This classification is for the purpose of epidemiologic description of cardiorenal syndrome, to collect data, to select patients for clinical trials and to see their outcomes. And this is there with every other classification. Now all of us know that the heart and kidney, they actually talk to each other through hemodynamic mechanisms as well as non-hemodynamic mechanisms. Now the usual interpretation that we have of the physiology is that for renal function, the heart is important because heart is the organ which pumps the blood in circulation, and this circulation is important to maintain the renal function. In addition, we know that these 2 organs are not only connected by circulation, but there are neurohormonal mechanisms. There are certain mediators, there might be some inflammatory mediators or reactive oxygen species which also coordinate the crosstalk between these 2 organs. But in practice, it is not only the pumping action of the heart which is important. Now, the heart failure can affect the kidneys in another way, that when there is a failing heart, what happens is that there is the venous pressure rises. Now, if you have a rise in the systemic venous pressure, it would translate into an increase in the venous pressure inside the kidneys. That is, you have an increased renal venous pressure, and as a consequence of that, what happens is that the perfusion pressure within the kidney declines. So what happens in a patient with heart failure, that in addition to the fall in the cardiac output, the congestive state which follows the fall in the cardiac output actually leads to a further fall in renal perfusion pressure. So it is not only important to actually increase the inotropic capacity of the heart, it is equally important to pull down the congestive state as well. Now, if we just imagine that we have a patient in emergency, or if we just look back at our experience in the emergency, the first thing that we do in emergency is broadly categorize the primary disease, that this patient is suffering from heart failure, lung failure, or whatever. So, if we look at the patients that we see in emergency, so we would actually characterize them as a primary disease, and the other things we would consider as ancillary disease. So in emergency department, if we look at those patients who have primarily a cardiac disease or who present primarily with heart failure, then we would have a situation that we would have patients who would be coming to emergency with either acute heart failure or exacerbation of a previously compensated heart failure, and they would have renal failure. This would be one category of cardiorenal syndrome. If we consider those patients whose primary diagnosis in emergency we would keep as renal failure, then we would have patients broadly in two categories. I don't know. Yeah. Now, if we look at those patients who would have a primary diagnosis of renal failure in the emergency, then we would have two broad categories: patients with acute kidney injury and patients with chronic kidney disease. Now, in these patients, they would have cardiac involvement either secondary to complications arising out of a uremic state or a fall in glomerular filtration rate, which would manifest either in the form of a fluid overload or a metabolic disturbances like hyperkalemia acidosis, which can pull down the contractility of the heart or predispose the heart to arrhythmias. Then in addition, we should realize that these patients, when they have cardiac involvement, they might have some systemic disease also, which would be affecting both the kidneys and the heart. Now, if we talk of chronic kidney disease patients, in addition to these conditions, the patients with chronic kidney disease who come to emergency department, another group would be patients with acute coronary syndrome. Patients who have chronic kidney disease and now have developed acute coronary syndrome. Now, if we see these patients in emergency, what are our immediate objectives? In patients who have a primary diagnosis of, let's say, heart failure, and now we know that they have renal failure also, we would like to know whether the kidney disease is acute or rapidly progressive renal failure or a chronic kidney disease, or in broadly whether it's acute or chronic, whether it is related to some drugs or interventions, because patients who have heart failure, they would be frequently on drugs like ACE inhibitors, ARBs or diuretics, which predispose to them to develop kidney failure. In addition, they could be subject to certain interventions like coronary angiogram, and then they can develop, after these procedures, they can develop acute kidney injury, which could be related to contrast, or which could be like atheroembolic renal disease. Then there are a standard set of interventions that we institute in the emergency room to alleviate their symptoms of heart failure. In the setting of renal failure, we should be aware that these things might need some modification. These therapeutic responses might need like drug dose modification in renal failure. And if the congestive symptoms are too much debilitating, then we have the option of extracorporeal therapy to remove excess fluid. Now, similarly, if we see patients who have primarily a diagnosis of kidney failure and now have come with some degree of cardiac involvement, then the immediate questions that we would like to answer are, as usual, that whether the kidney disease is acute or chronic, if that is the primary thing that we need to do. And if the primary diagnosis is renal failure and you have associated some degree of or suspicion of cardiac involvement as well, then you would be very much inclined to see the need for instituting any extracorporeal therapy, because that would rapidly alleviate the symptoms. Now, since the overall layout of the conferences that we are talking about cardiology, so my focus would be primarily on establishing in the emergency room, primarily on establishing the cause for our kidney disease. Now, whenever we talk about a patient with renal dysfunction in emergency room, there is a standard approach that we follow and which is applicable across the board. We look at the history to a certain risk factors. The common are hypertension, diabetes, and renal stone disease. But we should not forget recurrent UTI as well as voiding symptoms, which we frequently fail to ask. In addition, in our country, drug-related kidney disease is very, very common. So whenever we see a patient, we should be always talking about history, any temporal association of intake of a new drug. It could be a prescription drug or an over-the-counter drug like Ayurvedic drugs and other things. And we also frequently ask them for nocturia. But in the setting of heart failure, nocturia could be misleading because nocturia is a common symptom in patients with heart failure also. If the patient doesn't have heart failure but gives history of long-standing nocturia, then that suggests that possibly there is underlying chronic kidney disease. The second important thing that these things we immediately ask the patient. The second important thing we ask is, do you have any report of serum creatinine on urinalysis in the recent or remote past? Which would give us an indication. If it is there, it's deranged, then that suggests that possibly we are dealing with a patient who definitely has an underlying chronic kidney disease. We're not sure whether there is a superimposed acute kidney injury or not. And the third thing that we do are three simple investigations. One is serum creatinine, second is urine routine microscopy, and third is ultrasound, which are easily available in all the emergency rooms. Now let's see the interpretation of these investigations, these three investigations in this setting. If we look at creatinine, if it is increased, it automatically indicates there is a fall in glomerular filtration rate. And if you have a patient who in association has some degree of cardiac dysfunction also, you would be very watchful for development of complications in such a patient. So you would be looking for fluid overload, acidosis, hyperkalemia, and the only way to do is to serially monitor the patient. The frequency of monitoring would be based on the resources in hand as well as the equity of situation. Now, if the serum creatinine is normal, that actually in this situation would not actually rule out an underlying acute kidney injury, because you know that it takes some time for serum creatinine to rise. So if the clinical situation is like this, that you are suspecting acute kidney injury in a patient who has heart failure, but the serum creatinine is normal, continue to observe and pay special attention to his urine output, because over the next few hours his urine output may fall. And even if it doesn't fall, then you continue to monitor both serum creatinine and urine output. The second thing that we use is urinalysis. We look at the urine albumin, which we do by a semi-quantitative method by a dipstick, as well as a microscopy to look for, usually for RBCs and pus cells. Now this is something which is central to practice of nephrology. Now on the basis of urinalysis, when we talk of kidney diseases, we usually divide them into diseases of glomerular compartment, diseases of tubulointerstitial compartment, and diseases of vascular compartment. It is on the basis of simple urinalysis that you can categorize them. If you have albuminuria and associated microscopic hematuria and RBC cast, then that takes the diagnosis towards glomerular diseases. If you don't have these things, then that takes the diagnosis towards tubulointerstitial or vascular diseases. Now in the context of cardiorenal syndrome, this is important, because if you have a patient who has suggestion of glomerular cause of acute kidney injury, then that is not the mechanism you are anticipating in a patient with type 1, type 2, type 3 or type 4 cardiorenal syndrome. So then that should actually put a caution in your mind that possibly this is something else. Is it a systemic disease which is affecting both the heart and kidneys? The things that would come in type 5 CRS. And in these situations, we should always look for extrarenal symptoms. Now, if you have a tubulointerstitial kind of involvement, mild albuminuria and maybe some degree of microscopic hematuria, but no RBC cast, maybe some degree of pus cell, then that is consistent with a tubulointerstitial kind of injury, which is perfectly consistent with the mechanisms that we feel are acting in a patient with a typical cardiorenal syndrome. However, this does not mean that this patient cannot have tubulointerstitial injury due to other causes. So we should always keep in mind that it is consistent with that, but we should not forget that it could be, because if the patient is taking any alternative drug, then it could be a drug-induced acute interstitial nephritis, which would also, the urinalysis would not be able to differentiate between this and the mechanisms of cardiorenal syndrome. Now the third thing that we look at is an ultrasound, and it's very simple. On ultrasound we just need two things. The first objective of doing an ultrasound in a patient with kidney injury is to rule out obstruction. And the second objective is to look at the kidney size to see whether the kidneys are small or not. Because if the kidneys are small, then the diagnosis of CKD is not in doubt, but we cannot rule out in an acute situation in emergency room whether there is any superimposed acute kidney injury or not. So if a patient has small kidney size, patient definitely has CKD, but we cannot be sure whether there is any superimposed acute kidney injury or not. Now, with respect to the diseases which affect both heart and kidneys, it is important to remember that at times you might have an asymmetric kidney size. Now, if you have an asymmetric kidney size, then in that situation, you should think of a renovascular disease. And the most common cause of renovascular disease is atherosclerotic vascular disease, which can simultaneously affect the heart. You might have a cardiomyopathy or coronary artery disease and associated renal failure. Now, if we implement this basic approach, it is like this, that we are not deviating too much. We are just putting in heart failure and we are thinking 2 or 3 more conditions. So if we just look at this basic approach, we would be able to establish a diagnosis of kidney failure. We would be able to ascertain whether it is acute or chronic, and we would be able to, think of a possible etiology for kidney failure. So this simple approach in the emergency room would be very, very, I would say, helpful in getting a diagnosis. Now coming to the management. Now, the core focus of management in patients with any form of cardiorenal syndrome is relieving congestion in the circulation. Now, the type of therapy that we use, now there are various modalities by which we can assess the congestive status. The most commonly what we do is serial physical examination of these patients, but we know that the findings of physical examination might be erroneous, might be affected by other associated conditions, and the physiology is highly variable in such dynamic situations. So we have a lot of things like echocardiogram, ultrasound, bioimpedance analysis, then intra-abdominal pressure monitoring. There are some invasive monitoring also. So since we already have a lecture on assessment of fluid status, so those things might be relevant in that lecture. But overall, we all know that appropriate assessment or accurate assessment of fluid volume status in a patient who has both heart and kidney failure is actually very, very challenging, and there are no clear-cut protocols or guidelines on that. In these situations, the options that we have is diuretics, and most of these patients would be already on diuretics. Diuretics, the most common the therapy that we use are loop diuretics. But in the setting of renal failure, what we need to realize is that the efficacy of diuretics will automatically come down, because the delivery of loop diuretics to their site of action is dependent on glomerular filtration rate. So if you have acute kidney injury, low glomerular filtration rate, the efficacy of diuretics will come down. So in such a setting, if you are using diuretics, you need to use high dose as well as you need to use frequent dosing. Another important aspect which actually can be a part of exploration or which can be explored further is that usually we are using these criteria by which we assess the volume to see response to diuretic therapy. But another thing which can be done in this field is to assess the plasma refill. Because if we assess the plasma refill, we would be able to stop diuretics where we are actually removing fluid more than the rate at which it is refilling. So if the diuretics are not effective, then we have the extracorporeal therapies. We can put the patient on a hemodialysis machine and we can just remove or we can do an isolated ultrafiltration, a slow continuous ultrafiltration and things like that. So the interest in these kind of extracorporeal therapies has been there for long, and there are a number of clinical trials which have assessed the impact of ultrafiltration strategies, these extracorporeal ultrafiltration strategies in patients who have heart failure as well as some degree of renal failure. And in these clinical trials, you see the indication to start is not based on renal parameters or presence of renal failure or severity of renal failure. It is basically the degree of congestion that they have in their circulation. Though theoretically it is very much appealing that if the congestion is the primary reason why these patients are and they actually enter, as you had just seen in the previous slide, that it actually is a vicious circle. One thing leads to the other, the second to third, and the third to one. So it seems very tempting, but unfortunately when you do these all the clinical trials in real life situations did not show any significant benefit of ultrafiltration. In fact, the adverse events of these extracorporeal ultrafiltration strategies in this group of patients have been more. So as of now, these things are not recommended. But it is not like this that these are not helpful. In one particular patient who has an extreme degree of fluid overload, you are not able to take care of that, you will see that whenever you institute these therapies, they actually lead to an immediate symptom improvement. It's a different story that these things do not impact the long-term outcomes, because the long-term outcomes are not actually decided by these therapies, they are decided by their underlying cardiovascular and renal status. So for symptom management, these things are good, but don't expect a long-term improvement in outcome. Similarly, for increasing the inotropic action of the heart, you have vasodilator and inotropic therapies. There are a number of things. There are other drugs also which might lead to an increase, loss of sodium from the kidneys. A number of drugs have been used for symptomatic management of these therapies. But if you look at the summary of the literature, where if you look up any article, this is from the latest CRS guidelines which were released just last month, you see that the long-term efficacy in the treatment of acute heart failure and type 1 CRS of these individual drugs is still not clear. So these things, two of these drugs are FDA approved, tolvaptan and nesiritide. You might use these drugs for symptom management, but don't expect that these are going to ultimately change the outcome of these patients. Now another aspect is, if a patient has renal failure, the other aspect is institution of dialysis or institution of some form of renal replacement therapy. Now, in these patients also, the traditional indications for starting a renal replacement therapy or dialysis, they are applicable. These are refractory fluid overload, hyperkalemia or acidosis. However, in these patients, we need to keep our threshold for deciding elective dialysis as low. Because since their kidneys are impaired, and kidneys is the route by which all the conservative management strategies, they are critically dependent on kidneys to enhance sodium and water excretion. So if your kidneys are gone, then the efficacy of all the interventions is going to be very low. So that is why we need to keep our threshold for instituting any form of extracorporeal therapy in these patients. And especially the patients who have decreased urine output or are oliguric, they are at a very high risk. Now when we have decided that we are going to institute, let's say, dialysis in these patients, then what are the strategies that we have? Now these patients are hemodynamically unstable, they have associated heart dysfunction. So what we can opt for, instead of a standard hemodialysis, we can put these patients on slow therapies. Slow therapies which are now commonly available with standard hemodialysis machines also. One is the SLED, which is sustained low efficiency daily dialysis. Then you have now machines which come with hemodiafiltration. And of course, at bigger centers, you would have option of starting the patient on CRRT, which would allow a better volume control. One important thing that we need to keep in mind is that whenever such patients who are hemodynamically unstable are on some inotropes, whenever these patients are started on hemodiafiltration or hemodialysis, then their immediate requirement for inotropes will increase, because these things are cleared during these extracorporeal therapies. So we need to observe them, and we might need to increase their doses. Another form of dialysis which is available and which is frequently practiced in our country is peritoneal dialysis. However, peritoneal dialysis in this kind of setting where you have heart and kidney disease in the emergency room would be technically difficult, because we expect that patients who would have a refractory kind of situation would be obviously orthopnic. And in an orthopnic patient, it's technically difficult to do a peritoneal dialysis. But in patients who have a chronic condition, let's say chronic heart failure with some degree of renal failure or even chronic heart failure, people have used peritoneal dialysis to achieve some degree of extra ultrafiltration on top of diuretics. But again, as was there with ultrafiltration strategies through the hemo route, these strategies also have not been shown to improve the outcomes of these patients, and probably the reason is same, that the outcome is possibly related to the underlying diagnosis and not to the impact of this therapy. Now, another important thing is that when we see these patients in emergency room, it is not like this that they will always come to us with established kidney and cardiac failure. They'll come to us, maybe a patient will come to us with heart failure, his creatinine is normal, his urine output is also normal, but we know because of the kind of association that heart and kidney have, if his heart failure worsens, he would be at risk of development of acute kidney injury maybe 2 or 3 or 4 days down the line. So we need to have a strategy whether we can predict or whether we can segregate these patients into, whether we can do a risk stratification of these patients with respect to kidney disease. And for that, we need to identify patients who are at increased risk. Now, we already have serum creatinine and urine output, which actually establish the diagnosis, but